bedside. It's very clinically based, many hours at the bedside, I can tell you, and it's cardiogenic pulmonary edema and its management. Everybody in this room knows and understands what cardiogenic pulmonary edema is. I think in this talk I will emphasize the diagnosis of the underlying causes and the spectrum of diseases that can cause cardiogenic pulmonary edema, which can be difficult. And even diagnosing elevated filling pressures is the bread and butter of a lot of what we do every day in intensive care and occupies a lot of our time. The management of cardiogenic pulmonary edema is actually quite straightforward, and we will take a small look to the future and see what's coming down the track in intensive care terms. A good place to start in understanding cardiogenic pulmonary edema is at the microvascular level. In the normal alveolus, the interface between the capillary and the alveolar interstitium is tightly controlled by the junctions between the epithelial cells. And normally, very little fluid, the movement of which is governed by the Starling forces, the opposing hydrostatic pressure balance between the capillary and the interstitium, and the oncotic pressure balance between the capillary and the interstitium. Normally, very little fluid passes through the barrier, and any that is travels from the microvascular interstitium up to the peribronchial interstitium and is filtered away by the lymphatic system. In cardiogenic pulmonary edema, there is a massive increase in the hydrostatic pressures, such that the capillaries become distended and force fluid through the trite junctions into the interstitium. And eventually, the capacity of that interstitial capacitance becomes exceeded, and the lymphatics can no longer drain away all the fluid that collects. For rises in left atrial pressures from about 16 up to 25, that interstitium becomes very distended, but when left atrial pressure passes around the 25 millimeter of mercury mark, the alveoli become flooded. And we are familiar with that very abrupt acute onset of alveolar flooding that causes acute dyspnea and cardiogenic pulmonary edema. There are a wide spectrum of diseases that can cause, cardiac causes that can cause cardiogenic pulmonary edema. The commonest in our practice that we see is due to congestive heart failure, much more than half. The concept of congestive cardiac failure or cardiogenic pulmonary edema with a preserved ejection fraction, very well recognized. Up to about 30% of patients will present with that. Atrial fibrillation, common problem in intensive care, frequently precipitates increased filling pressures and edema. Cardiomyopathies by virtue of dilatation or stiff ventricles and like hypertrophic cardiomyopathies can cause edema. Left ventricular outflow in our environment doesn't just speak to aortic stenosis, but also dynamic situations such as anterior motion of the anterior motion of the anterior mitral valve leaflet causing obstruction in the left ventricular outflow tract, or hypertensive patients with chronic hypertension that have a bulging interventricular septum. If they get very dehydrated, conversely, can also get mid-cavitary obstruction that can acutely cause acute cardiogenic pulmonary edema. Atrial outflow, a less acute phenomenon in ICU. Mitral stenosis is a disease of decades, doesn't often present to us acutely. Occasionally we see myxomas or malfunctioning or thrombosis across prosthetic mitral valves. And then the mechanical complications of myocardial infarction, VSD, mitral regurgitation, always on the list. But I think a lot of the bread and butter of our daily life on the ward involves sometimes non-cardiac causes of cardiogenic pulmonary edema, and it's possible to overload a normal left ventricle with fluid. A classic example occurs in a massive blood transfusion situation. There is an optimum relationship between stroke volume and left ventricular filling, and that's the way the ventricle is designed to work. When the left ventricle gets very filled, it may plateau for a while, but then stroke volume will start to decrease. So you can overload a normal left ventricle, and if you work in an ECMO center like I do, you will be referred patients who are considered to have non-cardiogenic pulmonary edema, who go on ECMO, who are ultrafiltered with minus 10, 20 litres of fluid, and their acute lung injury disappears. They had fluid overload for whatever reason. they were required a lot of fluid to resuscitate them at the start. I think in terms of the population that we increasingly deal with in intensive care, who often have a lot of vascular disease, we tend to forget about the possibility of renal artery stenosis causing acute cardiogenic pulmonary edema. And we all now recognize the phenomenon of severe acute hypertension, particularly when patients are being weaned from mechanical ventilation, which Jean-Louis Taboul will speak about later in this session, that acute and abrupt rise in systolic blood pressure, often in patients who have chronic hypertension, and then followed very acutely by acute cardiogenic pulmonary edema. And the mechanism was delineated very nicely in this paper from Sanjay Gandhi in the New England Journal of Medicine in 2001, who looked using echocardiography at these patients during that episode of acute systolic hypertension and afterwards when they were treated. And he demonstrated that the rejection fraction was the same during both periods, so it wasn't related to an acute decrease in LV systolic function. He also demonstrated that it wasn't related to acute mitral regurgitation. It was related to diastolic dysfunction. And the problem of patients with diastolic dysfunction is they need to operate at higher filling pressures all of the time. That's how their ventricle adapts to being stiff. They increase their filling pressures and they preserve their stroke volume, so they're primed for pulmonary edema. And then the other factor in these patients is that their left ventricular pressure volume curves are maladapted. They're shifted upwards and to the left, so that for smaller increases in left ventricular volume, so the increase in afterload that occurs in systolic hypertension can shift fluid from the systemic into the pulmonary circulation, and a small increase in a left ventricle that is already has high left ventricular end diastolic filling pressures and as a maladaptive pressure volume curve causes a huge increase in left ventricular pressure and thereafter flooding of the alveoli. To change gears a little bit, I'm going to discuss a case that I had referred to me a few years ago of a 78-year-old man transferred after 2 days as an inpatient in another hospital because he needed dialysis, and that centre couldn't at the time provide dialysis for him. He had returned from a long-distance flight to Ireland from Africa, and after 5 days he collapsed quite abruptly at home. He required to be ventilated and a 24-hour period of needing vasoactive medications, and then he was extubated in that other hospital and went to their coronary care unit for monitoring. The working diagnosis was pneumonia because he had chest x-ray changes after recent travel. He had a pyrexia, elevated white cell count, and so typical and atypical antimicrobial therapy was instituted. A pulmonary embolism couldn't be ruled out since he'd had a long-distance flight and an acute collapse. There was no evidence of any acute coronary syndrome by ECG or troponin changes. And his chest x-ray looked like this. He had bilateral pulmonary edema, more marked on the right side than the left. When he came to our hospital, he looked extremely unwell. Tachypnic, fast atrial fibrillation, very vasoconstricted, maintaining his blood pressure, and no audible murmurs. The sort of patient when you saw you intubated and would ventilate immediately. And he required vasopressors, not surprisingly, as soon as he was sedated and ventilated. The dialysis was started, and we did do an urgent transthoracic echocardiogram. This echocardiogram is a parasternal view of taken from the front of the chest that shows the left ventricle and the left atrium. And the views aren't good because this patient is ventilated with acute pulmonary edema. His left ventricular systolic function looks low normal, but not dreadful. The color Doppler across the mitral valve here may show some mitral regurgitation. It's a little unclear. And from when we move the probe to the apex of the heart and look at the left ventricle in a more full cross-section, the systolic function does look preserved, and the lineup of Doppler here is very favorable to diagnosing acute mitral regurgitation because it's parallel to flow and we don't see a lot of mitral regurgitation. But because the image quality was poor, we did do a transesophageal echocardiogram. And when we performed a transesophageal echocardiogram, which this now shows the left atrium and the left ventricle, we can see almost instantaneously that there is an abnormality of the mitral valve that is associated with more than mild mitral regurgitation. And when we look at the mitral valve from a slightly different angle, this is very apparent that there is prolapse in the mitral valve that is associated with mitral regurgitation that you can just about see goes up into one of the pulmonary veins, which is the echo hallmark of severe mitral regurgitation. So the diagnosis changed instantaneously in this patient to cardiogenic, not non-cardiogenic pulmonary edema, which was secondary to severe acute mitral regurgitation. Slightly unusual and confounding by the fact that he didn't have any cardiac symptoms or signs. A balloon was inserted, he had urgent surgery and made a good recovery. And in terms of the spectrum of diseases that cause a cardiogenic pulmonary edema, the moral of the story is that mitral regurgitation is always on the list for ventilated patients with bilateral pulmonary edema. It might be bottom of the list, but it is always on the list. It will always require a transesophageal echo. It will never be sufficiently elucidated with surface echo, and that there are very few signs with mitral regurgitation, which is what the clinical trap is. So it always needs to be thought of, particularly in cardiogenic pulmonary edema, that is not resolving. Now, although that story is dramatic and shows you that the differentiation between cardiogenic and non-cardiogenic pulmonary edema matters hugely clinically to how the patient is treated, our job in intensive care is far less about those sort of eureka moments and much more about the patients who we all have many examples on our ward, who are partially treated pulmonary edema, inadequately treated pulmonary edema, who are difficult to wean from ventilators or difficult to move from CPAP or difficult to move from your ward. They just, even though you may be treating them for pneumonia or something else, they appear slow. And I think there is a lot of latent, unrecognized cardiogenic pulmonary edema and unrecognized elevated filling pressures among a lot of our patients. And the next part of the talk will deal with how we recognize that, and in particular, elevation of left-sided filling pressures, which of course are the linchpin in diagnosing cardiogenic pulmonary edema. Clinical examination, I think we all accept, is at best modest in estimating right and left-sided filling pressures. This study comes from the Mayo Clinic, from a group of faculty in cardiology and cardiology fellows, and they looked at 119 outpatients to their heart failure clinic, so nice, clean patients who should be easy to listen to and examine. And they compared their findings. All of the patients subsequently went and had a right heart cath, and they diagnosed right heart filling pressures in those patients who had a right atrial pressure greater than 10 and elevated left-sided filling pressures as patients who had a pulmonary capillary wedge pressure greater than 15. And by examination alone, they were right in estimating right-sided filling pressure elevation only 70% of the time. So a good third of patients misdiagnosed and even slightly less accurate on the left side. There was a slight difference between the faculty and the fellows, as you would imagine. The addition of using pro-BNP and indeed echocardiography didn't really improve the estimation of filling pressures in this study. Chest radiography, when it's dramatic, like in the example I showed you, is very obvious, but they're not the problem for us. The problem are the other patients. And in fact, chest radiography is not a good test for detecting cardiogenic pulmonary edema. This study in patients who had pulmonary artery catheters inserted with very elevated pulmonary capillary wedge pressures, very low cardiac index, and very poor systolic function, and by chest X-ray, in 27% of those patients, there was no congestion, and in 41% of them, there was little evidence of congestion. And I think that's what our problem often is. And similarly, another study from the Mayo Clinic in patients who were being worked up for cardiac transplant, when those patients, all of who had elevated filling pressures, but in 53% of the patients whose wedge pressures were between 16 and 29, they had no signs of pulmonary edema by X-ray, and 40% of patients with a wedge pressure more than 30 didn't have signs of congestion on their chest X-ray. And they're outpatients. Our patients have X-rays where they're supine, partially erect, and they're portable X-rays. So although this is what we look at and what we base a lot of our diagnosis on, it is a poor discriminator of cardiogenic pulmonary edema. Going back to the original microvascular level, the authors of that study, Michael Mattei's group in San Francisco, looked at the edema fluid itself that it's produced. And because the mechanism of cardiogenic pulmonary edema is that hydrostatic push of fluid across the membrane, the protein content of that fluid is very low. And they looked at the ratio of the protein content in the fluid versus plasma protein content. And the ratio was very low in the alveolar fluid. But it's not really a practical test at the bedside. Patients would need to be intubated, and very few of them produce enough edema fluid, which must be measured within 3 hours of production. So that's more a research tool for helping to understand the genesis and the resolution of alveolar edema. BNP, as Antoine mentioned earlier on, is a poor discriminator in intensive care, unlike in the cardiology outpatients where it is usefully used. So this study from Ran et al. Looked at the use of BNP using a much higher threshold than would normally be used in cardiology. Cardiology would use a threshold of maybe 100 picograms per mil. This study used a threshold of 250 picograms per mil to distinguish between patients with cardiogenic or non-cardiogenic pulmonary edema and the group that have mixed, and really it was a poor discriminator, and we don't use it in critical care. Very confounded in shock situations because BNP is produced by alveolar ventricular myocyte stretch, which can occur in a hemodynamic shock of any cause, and also very confounded by renal dysfunction, which is common in critical care. Echocardiography is incredibly useful for defining structures, cardiac structure that can be associated with pulmonary edema in terms of myopathies, LV size, in terms of function, in terms of valvular lesions, and also for estimating filling pressures on the left side of the heart with using Doppler echocardiography across the mitral valve or tissue Doppler at the mitral valve annulus, and the size of the inferior vena cava. And you can estimate right and left-sided filling pressures by echocardiography. As I said, IVC size used as an estimate of right atrial pressure, and left ventricular end diastolic pressure. Classically, we use the relationship between the E wave across the mitral inflow and the E prime, which is a tissue Doppler. And there are many parameters, and there are many studies that look at this. And the problem with echocardiography, and if we look at the last study here from Amen et al., that you must understand is that echocardiography doesn't give you a pressure. Echocardiography estimates what the pressure is likely to be. And it estimates it in this study, for example, which they compared their echo estimates with cath pressure measurement, and they found very good correlation. But the problem is this. The ratio that I've mentioned, if it's less than 8, there are low filling pressures. So the left ventricular end diastolic pressure, generally less than 15. If that ratio is greater than 15, the filling pressures are high, but they're spread at both ends, and there is a huge indeterminate area if that ratio is between 8 and 15. So echocardiography, I hate to say, is very good at defining structures that are related to cardiogenic pulmonary edema, but is neither a continuous monitor and it does not measure pressure. The other thing to say is that a lot of these measurements in echocardiography require sinus rhythm, which isn't always present in critically ill patients. And so if you need to measure pressure, if absolutely necessary for your patient, you must use the pulmonary artery catheter to measure right atrial and pulmonary capillary wedge pressure. Very, very commonly used when I was a registrar, so commonly used that it became a verb. We swanned the patient. You didn't swan the patient, to your other registrar colleagues, but it's no longer appropriate to use it routinely. And then I think in relation to cardiogenic pulmonary edema, these two trials in particular demonstrate why. In the FACT trial that looked at conservative versus non-conservative fluid management in ARDS, 1/3 of the patients with non-cardiogenic pulmonary edema had elevated filling pressures. And then in the ESCAPE trial in patients who had known cardiogenic pulmonary edema, who had pulmonary artery catheters inserted, there was no difference in mortality benefit to the patients with the pulmonary artery catheter. It is a diagnostic tool. If you've made the diagnosis, there's no utility. Just treat the patient. There's no utility in keeping the swan in, and it potentially may be associated with complications. So it is used on a case-by-case basis, as many of the other speakers said already, but not routinely in cardiogenic pulmonary edema. More recently, there has been in the literature a fair few publications on the use of lung ultrasonography. Its use is not new. It's around since the early noughties in critical care. And ironically, it's not a new phenomenon or a new, it's a utilization of an artifact that's present on ultrasound that is useful for demonstrating the presence of edema in the lungs. So on a normal ultrasound of the lung will look like this. This is a linear probe, so it looks like a square block, the ultrasound image. And this is the interface with the surface of the probe and the rib. And the white line is the pleural line. And at a equidistance between the surface of the lung and the white line is an artifact, which is a reverberation artifact in ultrasound. And that's a normal A line, a normal finding in a normal lung without edema. In patients with interstitial edema, the acoustic mismatch between the collapsed alveoli and the alveoli that are filled with fluid creates an artifact throughout all of those situations in the lung where it happens. And the artifact has a very classical appearance called comet tails or beeline artifacts. Now, it doesn't distinguish between, it doesn't delineate the etiology of the pulmonary edema, but it tells you that there is fluid on the lung. And the combination of this bedside technique that we can use in ICU with the echocardiography, which looks at the structure of the heart, is very, very useful for delineating cardiogenic pulmonary edema at the bedside. And I think a few speakers have already said about how mandatory it is for future trainees to be trained in ultrasound, but not just in cardiac ultrasound. I think in lung ultrasound, in critical care ultrasound, if you like, is becoming increasingly apparent. In this study from France, a group of 34 patients with cardiogenic pulmonary edema had this combination of lung ultrasound and thoracic ultrasound, meaning cardiac ultrasound used, and the sensitivity for diagnosing cardiogenic pulmonary edema was very high. More recently, a group from Mayo Clinic have published an algorithm that may be used at the bedside, again using that combination of cardiac and lung ultrasound. And they started with the lung ultrasound looking for B lines, and they divided the surface of the chest into 5 sections and studied each of those 5 sections for B lines on the lung. And if more than 3 of those sections had B lines, this gave the patient a score of 3. And then they subsequently did a cardiac ultrasound looking for poor LV systolic function. They did also measure or estimate filling pressures, looked at IVC ratio, and looked at for pleural effusions. And if the totality of the scores gained on lung ultrasound and cardiac ultrasound was more than 10, then that patient had cardiogenic pulmonary edema. And it was, as I said, more than 3 zones with B lines present that had the greatest sensitivity and specificity for diagnosing edema. So I think that's something we'll see much more of in the future at the bedside, an extension of the physical examination in the intensive care to supplement the X-ray, which is poor. The treatment of cardiogenic pulmonary edema is quite standard. Treat hypoxia because it causes vasoconstriction, use diuretics immediately, and treat anxiety and distress, again, which cause vasoconstriction and vasodilator. And although there has been synthetic BNP, for example, nasiratide, used, I think, briefly in intensive care, but associated with quite high incidence of renal failure, I think the mainstay still remains nitroglycerin as a vasodilator in this setting. Diuretics are a very big cornerstone of the medical management, particularly the loop diuretics that prevent the exchange of calcium and chloride and sodium and potassium in the ascending limb of the loop of Henle. And the beauty of the diuretics is whatever the systolic blood pressure of the patient is, they can be used. If the patient is hypotensive or hypertensive, the diuretic is used very quickly. It takes a half an hour to act and it peaks at an hour. So we used to say in the old days when we put in a lot of pulmonary artery catheters, I can tell you what the wage will be. It will be 12, because you will already have treated the patient and the patient will already have diuresed by the time you get the catheter in. It must be appreciated that in the group of patients that develop acute and chronic cardiogenic pulmonary edema, that they will require a higher dose of diuretic. The response to diuretic takes a shift downwards and is blunted. So they require a higher dose than usual of diuretic. Regarding the dose of diuretic itself that should be used, It has been the subject of a trial of low dose versus high dose, of bolus versus continuous infusion. And basically, this study, published in the New England in 2012, low dose meaning their normal dose intravenously, high dose meaning 2.5 times their normal dose intravenously. Not a huge dose, possibly by our standards. And then they divided the patients into either the low or the high dose given as a bolus twice a day or as a continuous infusion. And what they found was the patients who had the continuous infusions by the VAS score, which was a subjective score of wellness, of improvement of dyspnea, that they subjectively felt better with the continuous furosemide infusion than the patients who had the boli. There was no difference in mortality or time to hospital discharge, and that subjective feeling of improvement was associated with the deterioration of renal function. So more dysfunction associated with the high dose continuous infusion, but it wasn't permanent. At 60 days, when they looked at the patients again, the creatinine had come back to where it was in both groups. So acute renal dysfunction with the high dose intravenous infusion associated with a subjective improvement of symptoms. Ultrafiltration in cardiogenic pulmonary edema, not a routine therapy, again has been the subject of a trial, the UNLOAD trial, a non-blinded trial in a small group of patients that didn't compare it to diuretic, that did compare it to diuretic, and it didn't really look at our practice as much as the more ward-based or coronary care-based situation. And what they found was, again, no improvement in mortality, but a reduction in hospitalizations associated with, I guess, the fullness of the ultrafiltration compared with the probably less ultrafiltration associated with IV diuretics. Non-invasive ventilation, has been mentioned by Michael Pinsky, is really a cornerstone of the symptomatic management of cardiogenic pulmonary edema. It, compared to use of non-invasive ventilation, is associated with a more rapid reduction in respiratory distress, more rapid reduction in metabolic disturbance. Mortality benefit, slightly, I won't say controversial because there's no question of not using it, but slightly unproven. Bernstein's group in 2006 in the Lancet looked at CPAP in cardiogenic pulmonary edema, looked at performed a meta-analysis rather of many smallish studies, and showed a mortality benefit for the use of CPAP and BiPAP. And then a later study, which I don't have time to go into, by a group in Edinburgh, Gray's group in Edinburgh, didn't demonstrate the mortality benefit, but it does remain an important part of the guidelines and is a standard in treatment of care. So we have moved a long way in the treatment of cardiogenic pulmonary edema. This man was a very prominent Irish physician in the 19th century who, when you look at what they had to do, giving mercury to the patients with dropsy or pulmonary edema, they couldn't do much, but they could talk up a storm, and their powers of description are far superior to our ward rounds today. So we've moved away from that to the recent past, which is what I have really discussed in this lecture, the use of diuretics, non-invasive ventilation, and ACE inhibitors when they get to that stage, to the present, which in patients, as Dirk described, who fail conventional therapy, and somewhere in this mix of machines there is a AV ECMO circuit, to using those as a bridge to mechanical assist device, and we've had one or two of those in our ECMO centre, and hopefully the patient would get back to a situation where they could leave hospital and go back to a normal life with their LVAD as a bridge to a transplant. And eventually we will get to the stage where we will be giving them boosts of stem cells to pop up their left ventricular function to deal with the cardiogenic pulmonary edema. Looks like we'll have very little left to do if we reach that stage. What will the intensivist of the future do? Will we be joining Dermot Phelan in his boat in the west of Ireland? I hope so. Thank you very much for your attention.